So just to give you a little bit of background, very briefly, just to remind you, the incidence of cardiogenic shock ranges between 5 and 10%, depending on which series you look at in acute myocardial infarction. And it still has a really high mortality rate, despite many years of investigation and trials of different treatments, with a mortality of around about 50%, obviously higher in those that are older. And there are a number of therapeutic strategies for treating cardiogenic shock, all of them with the aims of trying to restore left ventricular function and cardiac output, and to support end organ perfusion and prevent the spiral of decline leading to multi-organ failure. And I'm going to focus specifically today on revascularization, pharmacological support, and hemodynamic support, and just look at some of the more recent data in these areas. Now, as part of the background, some of you may be interested in just the multi-societal guidelines that do exist, and these are just the ones from the last 5 years. So you can see it really is a hot topic, and lots of activity going on in this space at the moment. These are guidelines from the AHA and the ESC. So if we just look first of all at this particular guideline, which was really very focused on the practical management of cardiogenic shock, you'll see as I go through this figure that the color coding represents the standard class of recommendation, with green being a class 1, amber being class 2, and red being class 3, or don't do something. But this really just outlines, in the setting of acute MI, those with sort of structural complications. Obviously, those are patients who need revascularization and structural intervention, so fixing of the structural problem. But in the setting of straightforward ST elevation MI, obviously we want to revascularize the culprit lesion, but there has been obviously debate over the years about the non-culprit vessels, which we've heard about in the preceding session. So just to remind you, the trials in patients without cardiogenic shock have all been fairly similar in their findings, in that there seems to be benefit from complete revascularization in ST elevation MI, particularly in the absence of cardiogenic shock. However, when we look at the culprit shock data, we see that the results are quite different, in that there was no benefit and in fact potential for harm for complete revascularization. So suggesting that really just do the culprit lesion only. If we look at that trial in a little bit more detail, you can see it was a difficult trial to do, 700 patients randomized, with acute MI and shock from 83 centers. That still took 4 years of recruitment. There was a crossover rate, even during the index procedure, of approximately 10%, which is worth considering. But the primary composite endpoint was death or severe renal failure, leading to renal replacement therapy at 30 days. And these are the headline results. You can see the composite primary endpoint on the top, showing significant benefit from just doing the culprit lesion only, and that was echoed by the middle panel, showing that that was associated with mortality reduction, but no significant difference, even though the lines appeared to separate in requirement for renal replacement therapies. And if you look at the forest plot of the subgroup analysis, the pattern seemed to be consistent across the board. So what about the 1-year data? It's interesting that the 30-day results were not echoed at 1 year, and although the lines look like they remain parallel and separated, there was a small catch-up with the landmark analysis being performed after 30 days, showing that at 12 months there was actually no statistically significant difference then in mortality. What do we know about non-ST elevation MI syndrome? So NSTEMI, this isn't a randomized trial, but is a very large registry looking at approximately 25,000 patients and then matching them, propensity matching, to divide them into 2 groups, approximately 7,500 patients in each, either who had culprit vessel-only PCI or multi-vessel PCI. And again, you can see that there was a signal of reduction in hospital mortality in those that had multi-vessel PCI in NSTEMI, But really, once you get out to 1 year and following out to 7 years, no difference in mortality again. Again, this is just observational. So in conclusion, I think the take-home messages and the guidelines would say, really focus on the culprit lesion and do not, in routine practice, consider multivessel revascularization during the index procedure. But that still leaves open the question about the potential for staged non-culprit PCI, either during the index admission or after discharge. So what about the next step in the algorithm? We've talked about revascularization. Well, the next step really is around high dependency unit care, particularly around pharmacotherapy. And you can see here intravenous inotropes and vasopressors get a 2B recommendation, typically with a level of evidence B or C, so not very much data to inform our practice. There is a Cochrane Library review specifically of pharmacotherapy, which you can see here on the bottom left if you are interested in looking up all of the studies that have gone into producing these guidelines. But what do we have from recent pharmaceutical trials? Well, you can see here comparison of epinephrine versus norepinephrine. It's a small study, only of approximately 30 in each arm of the trial. There was some minor differences in hemodynamics in the first 6 hours, which weren't sustained out then over the following days. The difference really only came into those that had refractory shock, showing that there was a reduction in refractory shock with norepinephrine versus epinephrine. So again, that is what is reflected in the guideline recommendations. Comparisons also have taken place. This is something from 2021, last year, comparing milrinone to dobutamine. Again, a relatively small trial of only approximately 200 patients, but no differences with using different types of inotropic agents, such as milrinone, PD3 inhibitors, showing no difference in the primary composite outcome, and certainly no difference in in-hospital mortality from any cause. So just turning finally to the last step of the algorithm, which is mechanical circulatory support, and let's have a look at some of the data that underpins that, because that certainly is where a lot of the research activity is focused at the moment. Obviously, there isn't time to talk about all the different treatment options for mechanical circulatory support, so I'm going to just focus on these 3 different strategies, so intra-aortic balloon pumps, impeller device, and VA ECMO. And again, just give you a quick update on the data from the recent trials. So here, this isn't a recent trial, actually, this is back 10 years now, but just to remind you, the IAB SHOCK 2 trial results, which was really a randomized trial of balloon pump versus control, showing absolutely no difference in mortality at 30 days. And again, equipoise really across the strategies on the forest plot for subgroup analysis across many different domains of patient characteristics. So no benefit in a randomized trial of balloon pump support. Turning now to the impeller device, this is actually this is a very large registry from the US, just looking at impeller experience across a large number of centers, and essentially showing that using impeller support for acute MI and cardiogenic shock, there's actually wide variation in the outcomes. So you can see here, survival to explant mean was about 50%, but in high volume centers, then survival rates could be up to 76% to explant versus low volume centers, it might only be up to 30%, but clearly there's potential for considerable bias here. It may be that the high volume centers are much better at it, but equally it could be that they're just much better at selecting the patients who I think are going to be the most likely to benefit and survive. So it doesn't tell us everything we need to know when we look at registry data of this nature. Here's some more Impeller data. Again, not a randomized controlled trial, but just, again, matching Impeller patients from a registry to those from the IAB SHOCK 2 trial. And you can see here on the Kaplan-Meier curves that absolutely no difference between Impeller treatment or treatment with IABP or medical therapy from the SHOCK 2 trial. So again, it doesn't seem to suggest a signal of benefit from using Impeller device. But again, this isn't a trial, this isn't randomized. So just for the last couple of slides, I'm just going to turn briefly to VA ECMO. There have been a number of early studies showing quite large potential benefits from this as a treatment modality, but as you know, in many small early observational studies of new strategies and devices, often the treatment effect does appear to be quite large, and that often doesn't bear out when it gets subjected to a randomized controlled trial. So just to give you some really late-breaking sort of news, this is from the American Heart Association just a couple of weeks ago. This was the randomized ECMO cardiogenic shock trial, simultaneously published and available online in circulation. And just to give you the headline results, this was a large multi-center randomized investor-initiated trial of immediate VA ECMO or no immediate VA ECMO, 122 patients with deteriorating or severe cardiogenic shock. But notice here, there's quite a mixture of etiologies. So it could be STEMI, NSTEMI, decompensating heart failure or mechanical complications. And what you see here from that composite primary endpoint, that there doesn't appear to be any significant difference between the two arms, either in terms of the composite primary endpoint or all-cause mortality. So that really is the sort of right up to date from just the last 2 weeks. So I think in conclusions, we can see that cardiogenic shock remains a devastating condition with high 30-day mortality, limited high-quality randomized controlled trials to guide our practice. In the setting of a STEMI, certainly immediate culprit-only lesion treatment appears to be the preferred option, although there is still the question around stage complete revascularization. In terms of medications and pharmacotherapy, standard inotropes, there are no novel therapeutic strategies that have been proven at the current time. And in terms of LV support, there doesn't appear to be an obvious benefit in STEMI from balloon pump insertion or from impeller insertion. And from the recent ECMO CS trial, there doesn't appear to be benefit in VA ECMO, although, as I said, this wasn't just a STEMI population. So there are 4 large randomized controlled trials underway at the moment in the proper STEMI population, if you like. 2 of them, I think, that I've highlighted here at the bottom are due to report in 2023. So I think we'll have results from those hopefully soon, and that will then give us further insights into the benefit of this particular device technology in ST elevation MI. And thank you very much.